Irv Khrushchev. Let me say a few words about Irv. Here he is, the debonair, handsome devil. Probably Irv in the 1970s, when Irv started producing many of the articles that we relied on early in our careers in neuroradiology. I just have to mention many of the accomplishments. I knew about this from my long association with Irv and with neuroradiology, but in looking over his CV, it was apparent that in virtually every area of neuroradiology, Irv has made significant contributions. In angiography, in our early days when we localized masses by their angiographic vascular displacement, describing angio techniques, describing cerebral vascular anatomy, contrast material and their indications and contraindications, vascular disease and quantification of blood flow. In CT, when CT first came on the scene, Irv was one of the first people with his co-authors to describe cerebral anatomy, pituitary and paracellular masses, spine disease, all of which made it into the best journals in radiology. Even in interventional radiology, the use of particulate matter and balloon embolization for carotid cavernous fistulas. Here's Irv in his classic pose and the over-the-shoulder, don't give me that bull, Irv Khrushchev tone, which we all have accepted as a challenge when we make certain comments and describe certain things in neuroradiology. As Eddie mentioned, he has had many recognitions throughout the world of neuroradiology. He's been president of the ASNR and, as mentioned, has won the gold medal from both the RSNA and the ASNR editorial boards, too many to mention, and of course, multiple committees in national radiology societies. And this is the Irv we all love and know and we honor here today. And again, it's a pleasure for me to be able to deliver this lecture. So this is the Irving I. Khrushchev lecture, and I'm going to talk about spinal cord injury, imaging, clinical and surgical considerations, and at the end, a look into the future. So we have to say a few things about what Irv has done with his co-authors in spine injury. One of the earlier articles in evaluating spinal injury, spinal cord injury, was written right here from NYU. I noticed whenever I called Irv's name up on the internet, it always came up in red, and I wonder if that was something that he had specifically requested. But here is one of his earlier articles on the positive and negative contrast myelography in spine trauma, in which they used positive contrast material when there was not significant bone displacement and negative contrast when there was. That was an early important article. Then, of course, you know, when we investigated spinal cord injuries with water-soluble contrast myelography, installation of this through the C1, C2 approach became very popular, and this article described the lateral puncture at that level. And then, of course, some of the work that I've done and we've done in Miami, the Miami project, involves animal work. And as I went back, I noticed again that Irv and his co-authors examined with water-soluble contrast agents some of the same things that we're looking at now. What kind of injury results in syrinx formation, myelomalacia, or what kind of injury results in no permanent damage to the spinal cord? And this was done with metrizamide, and the experimental animal was a cat in which they had a crush injury to the cord and then actually looked over a time period the contrast entering the cord and tried to determine exactly what leads to a cyst in the cord, what leads to myelomalacia, and what may result in a normal cord after such an injury. And now we've come, as you know, to look at MR under these circumstances, and I'll touch on some of that in this presentation. So let us look at what we're going to talk about. There's going to be three parts to this spinal trauma talk. Part one is going to be the evolving concepts in imaging the spine injury patient. The second part is going to deal with MR and the acute, subacute, and chronic stages of spinal cord injury. And this, I feel, is very important because there's a lot of patients out there that could benefit from a very thorough radiographic workup and aggressive surgical care of them. And the part three will talk a little bit about the future of spinal cord injury. Where can imaging help in experimental investigations? And not only that, but what is the future? Where are we going with the work in spinal injury in general? So I'm going to put aside all the classic teachings of mechanisms of spine injury and just pose to you a few critical questions which we all should think about when we're looking at a patient who's been admitted to a trauma center. And this is the experience from the Ryder Trauma Center at the University of Miami and Jackson Memorial Medical Center. And here are the questions. Are plain films sufficient? Under what circumstances are plain films sufficient? Is CT always necessary? Under what conditions is CT necessary? Is a combination of plain films and CT required? When should MR be performed in acute spine injury or acute spinal cord injury? Should it always be done, or should it just be done under certain circumstances? And how does the recommended imaging vary with the clinical assessment? So on the top is the Ryder Trauma Center, and on the bottom is the Lois Pope Life Center, where a lot of the work on spinal cord injury takes place on an experimental basis. So let's start with spinal clearance. So now we all know that it's well documented that plain films miss a significant number of fractures of the cervical spine. Many people didn't originally believe this, but experience has shown and reports in the literature that up to 1/3 of cervical spine fractures are missed with plain films alone. So we ask a question, what about the rest of the spine? Well, most people's experience is the same story occurs in the rest of the spine, but in the literature, it's just not as well documented as it is in the cervical spine. And we all know the problems of looking at the thoracic spine on plain films. So we can say that, that probably the number goes anywhere from 20 to 35% of missed fractures of the spine with plain films alone. But of course, now there are different types of patients that are admitted for evaluation for, quote, spine trauma. We either have patients that are brought to a trauma center because they've been involved in a significant accident, or there's patients who come into the emergency room for less significant spinal trauma. And we can say that in the trauma center, both plain films and CT are being used at the assistance of the orthopedic surgeons and neurosurgeons, despite the evidence of the value of just performing CT with multiplanar reconstruction. What I'm trying to say is we believe very strongly that a patient can come into a trauma center and have CT alone and high-quality CT with reconstructions. And you don't need plain films, but we continue to do them just at the insistence of our surgical colleagues, and you all know how that goes. And this is the protocol we use. Now, in the emergency room, where somebody may have a very insignificant injury, maybe just a little bump in the back of the car, or some such relatively insignificant trauma, plain films are the first line of defense, the first study. But of course, then we do CT in any case where the patient has significant neurological symptoms or severe pain, or obviously if the patient is obtunded, then you can't evaluate very well the patient without CT. Plain films are negative and the patient's alert, just the clinical evaluation is recommended. And then of course, if there's any question of an abnormality on plain film, CT is performed. So that's basically the protocol we go through. So I'm going to take you through a few images and just ask you, do you see any fractures here? You a lot of films to see in an emergency room and a trauma center, and you look and the spine lines up pretty well, and the spinal laminar line looks fine, and no subluxations, and then you go on and you do a CT in the same patient, and you see the significant fracture through the lateral portion of the body of C2, which really is not that evident until, of course, you get the CT, and then you go back to the plain films and it becomes evident. So there it is. And we all know with these overlying lines that, that you may miss something very simple like that. That same patient actually went on to have an angiogram, CT and digital subtraction angiography, and right at the level where there was that fracture, we can see the vascular injury here of the vertebral artery. And so any fracture that extends through the transverse foramen in the region of the vertebral artery should be evaluated with some study to look at the vertebral arteries because the incidence of abnormality, vascular injury, is quite high, and that's been reported in the journal Spine, high incidence of that. So there are advocates of performing MRA or digital subtraction angiography in cases of significant spine fracture because of the incidence of vertebral artery thrombosis and vertebral artery dissection and vascular injury, as you see there. Now, just as Dr. Meng had shown earlier, these dissection and subintimal hematomas in the carotid artery, you can see the same thing in the vertebral artery. Even in minor injuries with no fracture, there may be a vascular injury. Of course, then you have to rely on the clinical symptoms. And here's a patient who was turned very quickly to look at her children in the back seat of her SUV while there was a accident ahead of her on the road, and she had a pain in her neck. She came in for a standard CT plain film evaluation, and all this was negative. Of course, then when we looked at the axial imaging with T1 fat-sat image, you can see this dissection along the wall of the vertebral artery on the right side, and the patient demonstrates this long hematoma, subintimal hematoma in the right vertebral artery. So there's a good reason to look very carefully at MR and to be very aware of the possibility of a vertebral artery or even a carotid dissection in cases of trauma. Another case, any fractures. You look at the fairly nice plain film here of the spine and the lateral and AP projection. And then, of course, there's a fracture here through the pedicle on the left side at C4, C5, and right through the region of the vertebral artery on the left side. Jefferson fracture, well, we all can recognize quite clearly the separation of C1 and C2 at the odontoid level, but how much clearer this is on CT with the multiple fragments ring fracture of C1, vertical compression fracture, as we all know. So now let's turn slowly toward the MR and try to talk about where it is indicated. Now here are two classic fractures of the odontoid. I didn't show a type 1, which of course is the tip of the odontoid, but here's through the neck on a type 2 and down through the body of type 3. Fairly clear that this patient has a fracture at this level. Why would anyone do an MR scan on somebody like this? You put the patient in tongs, and with such an injury, though, you may miss some important findings, and here is a axial MR scan through the level of the odontoid and the C1 ring anteriorly. And I want you to look carefully at this because the transverse ligament comes into play here. And in this particular case, there is a tear, a separation of the transverse ligament from the C1 level. And we can say that this demonstration or the MR evaluation of the transverse ligament has important therapeutic implications because avulsion of the transverse ligament requires early surgery, and that is what our surgical colleagues believe and do right now. Without surgery here to cause some sort of reattachment and stabilization at at the C1, C2 level. These patients fail conservative therapy compared to patients who have just a bony fragment avulsion. So it's important to look at this thing, and there's the tear of the transverse ligament. So we can ask, is CT alone enough? And we could conclude that current literature supports the use of CT alone in trauma cases. And assessment of subluxation is difficult on axial imaging, but with multiplanar reconstruction, evaluation of the alignment of the spine is possible. And then, of course, we can always use plain films for dynamic evaluation of spine, but that is not an urgent situation in an emergency room setting or in a trauma setting. So now we're going to move slowly on to MR. And there are a number of important observations in acute spine injury, and most of you are aware of what those are. But I do want to point out some important things and where this field is going. This issue of non-hemorrhagic, well, first of all, in a contusive injury of the spine, people talk about hemorrhagic and non-hemorrhagic contusion. But in reality, in every significant spinal cord injury, there is always some hemorrhage. Now, you might not see it even on gradient echo imaging, but on pathology, there's always some evidence of bleed. So we can throw away the notion in a significant spinal cord injury, there is non-hemorrhagic contusion. There isn't. There's always some degree of hemorrhage, whether we see it on MR or not. We can talk about low velocity, a compressive spinal cord injury. This issue of displaced spinal cord tissue, I don't have time to go into a lot of this, but this is a pathological observation that we now can make on high-resolution MR, where we can see at the above or below the point or equator of a spine injury displacement of spinal cord tissue. And I'll get into that a little later, but this is the reason why at areas remote from a spinal cord injury, you can actually see cavitation of a spinal cord, because this displaced spinal cord tissue loses its normal vascularity and undergoes some sort of necrosis. So not all these things, therefore, are syringomyelias. They're cavities from necrosed displaced spinal cord tissue. And of course, we all know that you can have an acute herniated disc in the absence of fractures. But the major question we have to ask ourselves is, when do we obtain an MR on an acute basis, and does it make any difference? Does it make any difference that these patients get MR? Well, a couple things we can also say. First of all, it's difficult to get patients scanned in the hyperacute phase when theoretically decompression of the cord could be important. There are a lot of theories out there that if you decompress the cord early, then you may negate progressive vascular injuries to the spinal cord, which are greatly underestimated in the setting of acutely injured spine patient. I'll get to that in a second. In addition, there has never been a randomized study to prove that acute decompression improves outcome. I was part of a committee by the AANS, the American Association of Neurological Surgeons, in which they tried to get a randomized study on patients to have early decompression of spinal cord injury, and they could never get this approved because almost everybody who comes in an early phase of an acute spinal cord injury into a major center probably will get some sort of decompressive surgery, because the feeling continues to be that early decompression does make a difference. And probably the most beneficial use of MR is in patients who have an incomplete neurological deficit, or in whom there are progressive or worsening neurological signs. So if you have a patient who comes in who's a complete injury, has a complete quad, there probably is not a great value outside the window of a few hours of getting an MR, but it's the patients who are incomplete or who are progressive that MR is very valuable. Well, we all know that you can have somebody who's had a significant injury, you do plain films, you do CT, you see minor subluxation here, you can see the facet sublux, and If you don't do an MR, you may miss an acute herniated disc, such as you see over here on the right side. So that is, everyone's aware of. So that is, of course, a person whose plain films or CT are relatively benign looking, but who may have a real significant lesion. You can also see some edema in that disc space. Hemorrhagic contusion. Well, this is a sort of an old image, but it's a gradient echo image, and we all know that the gradient echo or susceptibility images show hemorrhage the best. But look where the hemorrhage is. The hemorrhage is in the deep gray matter of the spinal cord. It's a particular target for hemorrhagic changes because this is the highly vascular region of the cord. And as I said earlier, vascular changes, particularly venous thrombosis in the spinal cord injuries, have been greatly underestimated. So now let's look at a few cases. Here's a patient who had a motor vehicle accident. It was a C3-4 fracture subluxation, a quad, and the patient died 3 days following injury. Now, I have to emphasize, you're going to see some pathology here. It is very unusual to get pathological specimens in a patient who has a spinal cord injury, because with modern therapeutic care of these patients, they tend to live much longer than they used to. This is a patient who has, as you can see here, the T2 weighted images and axial images through the level of hemorrhage and at the C3 level, just to re-emphasize in our own minds where hemorrhage occurs in the deep gray matter predominantly and at the C4 level. Now, it's been pointed out to me by our pathologist that we shouldn't call these hematomas. He prefers to call these hemorrhages, and the reason for it is that these are, again, hemorrhagic contusions. They're not solid areas of blood like we see in a hematoma, but they're admixed within neural tissue. So these are hemorrhagic contusions. Actually, if you look carefully at this, you can see some neural tissue embedded in these areas of hemorrhagic contusion. So what can we find? Okay, so we all know what hemorrhagic contusion looks like in the cord, but there are other important findings that are useful in patient care. Here, of course, the prevertebral edema, soft tissue swelling, no news to anyone. The rupture of the anterior longitudinal ligament, often overlooked in evaluation of the MRs, but important in stabilization, if you're going to do a stabilization of this patient over multiple levels. Blood in the extraaxial space that you'll see better on the axial image. And then, of course, a tear of the dura, and you can see the arrows pointing at a tear of the dura with leak of CSF out into the paraspinal region, and extension of that fluid down along the anterior aspect of the spinal canal. So there are other important findings that we can make on MR besides the fact the patient just has a hemorrhagic contusion within the cord. So we can say that MR is valuable in the evaluation of the soft tissues, including the ligaments, and may conceivably direct a different surgical strategy than would have otherwise been performed in such patients. Now, in this patient, I show you a series of images because this is going to lead us toward the chronic or subacute injury. Here's a patient who had a severe injury of the spinal cord, and you can see the edema above and below, and careful inspection of the image shows some areas of low signal, which indicates small areas of hemorrhagic contusion. And this following set of images is a 5-year follow-up after hemorrhagic contusion. The patient had increasing pain and motor dysfunction. Now, this is 5 years later. And the patient obviously had an ACDF, and now there has developed this apparently enlarged cord. But this is not really cord enlargement, although it looks like it. Actually, what's happening here is the pial surface and the dural surface is attached to the anterior and posterior portion of the spinal canal. There's developed a small cleft or small cyst. So this is really tethering of the cord. And this is a point to be made that when these patients undergo decompression, I'm going to get into this in a second, they actually need to have formed by the surgeon not just stabilization, but reestablishment of good CSF flow, hopefully anterior and posterior to the injured cord. If they don't, they're setups for a long-term neurological progressive dysfunction. So the initial treatment of a burst fracture, as you see here, consisted of an ACDF, and this is a common result if these patients are not treated properly. And this we would consider these days an improper, incomplete treatment of that burst fracture. So let's talk about this, what has been called a central cord syndrome. It's an acute post-traumatic event, low velocity injury, and this injury on MR to us as radiologists is a non-hemorrhagic injury. It's basically involvement of the cortical spinal tracts, non-hemorrhagic on MR, and I will say again to emphasize this, there's probably value of early decompression of a spine following injury, having a bony decompression within 12 hours in all types of spinal cord injury. But as I said, controlled studies have never been proven, have never been done to prove that this is actually efficacious. And here you can see this patient with multi-level spondylosis and this high signal within the cord and a typical clinical picture of a central cord syndrome. The pathological correlation of such a patient shows this loss of myelin in the cortical spinal tracts. And here you can see preservation of the ascending spinal cerebellar tracts, but bilateral demyelinization of the, or loss of myelin, I should say, in a patient with central cord syndrome. And that's the underlying pathology, not a large central hematoma, as has been described in the orthopedic and surgical literature. And we, I hopefully proved this in an article we wrote about 10 years ago, showing no hemorrhage in a large series of definite central cord syndromes. No large hematomas. Now we move to subacute spine injury, and we'll talk about a number of things: Wallerian degeneration, early cavitation due to the devitalized parenchyma, which I briefly mentioned before, early development of schwannosis. And I won't go into this, but I want to just mention that as we get better and better imaging, maybe perhaps with the 7 Tesla system that's going in here at NYU, we're going to begin to see very strange appearances of an injured spinal cord. And what you're going to see are areas of what the pathologists now have determined are schwannosis. What is schwannosis? Schwannosis is the development of a conglomeration of Schwann cells within the injured spinal cord. And unfortunately, these areas form a barrier to regeneration of normal spinal cord tissue. That occurs because there's ingress of Schwann cells either through the dorsal roots or ventral roots into the spinal cord because of a trauma to the cord itself. And then we'll talk about acute, subacute, post-traumatic ascending myelopathy, or what the surgeons call SPAM. So let's just talk about these two things. Wallerian degeneration is seen almost routinely on high definition MR scans about 4 to 6 weeks post a significant cervical or spinal cord injury. It can be detected earlier on diffusion weighted imaging, and we must recognize that this is a normal sequela of severe spinal cord injury. It could be important in the timing of interventions and interventional procedures. So we all know that if you have an injury here in the spinal cord, you'll get ascending degeneration, Wallerian degeneration in the dorsal columns, and you'll get descending degeneration in the cortical spinal tracts. There's even what we call dieback phenomena, which I won't get into, which is actually retrograde. Mostly what we see is antegrade degeneration of the dorsal columns and the cortical spinal tracts. And this is the pathology of such. This is above a level of injury, loss of myelin in the fasciculus gracilis, and to some extent in the fasciculus cuneatus, and here's the myelin stain. This is a post-mortem MR. And below the level of injury in the cortical spinal tract with preservation of the ascending spinal cerebellar tract. This is the cortical spinal tract. So, are there future strategies to slow or arrest Wallerian degeneration or to intervene before extensive degeneration occurs? That's an important question. Post-traumatic Wallerian degeneration, clear-cut injury to the spinal cord. You can see the loss of height of the vertebral body, this low signal on a T1 weighted image. This is a T2 through the level of injury, not much to say about it. But above the level of injury, on a T2 weighted image, of course this is T1, this is T2, well-defined area of loss of myelin in the dorsal columns. That is post-traumatic Wallerian degeneration, and in the lateral cortical spinal tracts descending below the level of injury in the lateral columns. This occurs over a period of time, and here is a 2-month follow-up in a patient who had an injury here. This level is up here at the C2, 3 level, and then 2 months later, you begin to get this ascending Wallerian degeneration within the spinal cord. So look for it. It doesn't mean it's a second area of injury or vascular injury. It's just part and parcel of what we expect in all types of Wallerian degeneration, whether within the brain or within the spinal cord. And here's another example. This is below a level of injury, and you'll notice these 2 or 3 areas of high signal, and this is down below the level of injury at the mid-cervical region, and these are areas of Wallerian degeneration within the lateral cortical spinal tracts and in the anterior cortical spinal tract, which you see there. Now there is in the subacute phase, there's an important observation that our surgical colleagues are well aware of, and we should be too. And there was a paper delivered at the RSNA just 2 weeks ago on this particular entity, and it's becoming increasingly recognized by radiologists. And this is this subacute progressive ascending myelopathy. It is a very acute type of problem, and it's a delayed deterioration within days after a severe injury to more than 4 segments above the original injury. It is unrelated to mechanical instability. There's high signal on T2 weighted images. The cord becomes enlarged. And the clinical outcome is that the patients usually improve but never return to their baseline that they were after their injury, and this is occasionally fatal. The etiology is unclear, and there's all sorts of theories, whether it's a progressive arterial or venous infarction, or if it's some sort of overwhelming autoimmune response to this massively destroyed spinal cord and secondary changes in the viable cord above it. Let's look at what this appears. Here's a patient who had a fracture subluxation in the thoracic area. This patient had an instrumented fusion 1 day post-injury, and now 7 days after this, you can see the patient's had a fusion. The T1 weighted image shows this markedly enlarged spinal cord all the ways up into the cervical region. If we look at the T2 weighted images, now here's where the patient was injured and fused. Here is this high signal. Now we're only 7 days after the injury. This patient was having rapidly progressive neurological dysfunction. And now 17 days, now we're going 10 days after the last image I showed you, further neurological deterioration, and here all the ways up into the cervical medullary junction, there is this high signal. This is called SPAM, subacute progressive ascending myelopathy. We must be aware of this possibility in patients who've had massive injury to the cord. How about chronic spinal cord injury? What do we see? Well, there are a whole host of things, and I'm only going to touch on those things which I believe can be surgically attacked. We can have progressive myelomalacia, cavities and expanding cysts, which we all know about. This issue of cord tethering and intradural scarring is very important. Cord atrophy, subarachnoid cyst, cord herniation, and progressive spinal deformity. So let's talk about these because these are the most important changes in spinal cord injury chronic because they are frequently encountered and surgery may be performed. So now, this issue of what's a cavity and what's a cyst. I prefer to use the term cavity when there is a clear CSF equivalent space within a cord in which the cord is not expanded, saving the term cyst to connote a equivalent signal in which the cord is expanded. So we have expansion, cysts, cavities, these slit-like areas. On pathology, these tend not to have well-defined borders. Okay, so here's a patient who's had an injury. It gets back to this issue that I mentioned before. Why, if the patient is injured here, does the patient have a slit-like cavity down there? And you can see these above or below an injury, and we believe it's necrosed displaced spinal cord tissue. We have pathology of that, which I don't have time to show you here. But this is the pathology of a patient who has one of these slit-like cavities. There is no well-defined border. There is just this loss of neural tissue, neuroglial cells around this without an astrocytic border. So the question we can ask is, could a cavity such as this be a good receptacle for cell transplantation or injected neural growth factors? And as a matter of fact, a number of institutions are looking at that on an experimental basis, seeing whether in experimental animals you could actually inject stem cells or neural growth factors into this and perhaps promote or wake up hibernating neurons in the general vicinity of a spine injury. And I'm going to talk about that toward the end of this when we talk about futures. Spinal cord cysts, these are ones that expand the cord, and they may very well have a well-defined astrocytic border. You ask yourself, well, so what? The point is that because of this barrier, an astrocytic barrier, a glial barrier, these may be a poor receptacle for the deposition of stem cells and neural growth factors, because this would be an actual border for any of these growth factors to get into the surrounding neural tissue. So that's another area that we're looking at very carefully. So this may be a barrier to cell transplantation, and I would suspect that in 10 years or so, radiologists will be deeply involved in assessing these cysts and their border as strategies develop to take care of these spine injury patients. We're all aware of ascending post-traumatic spinal cord cysts, which have also been known in the past as post-traumatic syringomyelia, and I want to emphasize that it is the initial inadequate decompression of a spine that results most probably in the development of these spinal cord cysts. So now, when you look at these in the future, look at the area where the injury initially occurred, and you'll find almost inevitably that at the level of injury, there has been an inadequate decompression of the subarachnoid space. And so what happens is the normal pulsation of CSF comes down, hits the barrier where the cord is adhesed, the canal is narrow, and fluid gets directed into the spinal cord and then dissects, if you will, into the central canal or into cysts that are around the central canal, and over time, over months to years, develop these ascending cysts. So we want to get away from this. And the more the surgeons adequately decompress initially, the less and less of these syringomyelias post-traumatic you will see. So we evaluate this. I don't want to get into this too much, but just to show you, we evaluate these spine injuries with intraoperative sonography. Just to show you an example, this is a cyst within the cord. This is a dense adherent dura. The surgeon goes in, that's what he sees. He opens up the dura, and he has this scarred down pia to dura, and you can see some of the granulation tissue there. But what he does then is take some freeze-dried dura and forms a patulous subarachnoid space. Doesn't shunt the cyst anymore like they used to, but just makes a big subarachnoid space, and immediately, like within a couple days, the whole syrinx just decompresses. So what we do is we look at CSF flow, and later on this afternoon when I talk about dilemmas in spine imaging, I'm going to show some cines of some cord tethering. I don't have a chance to do this now, and of CSF flow, but it's an important adjunct to evaluation of the spine on MR. And so now you look at this patient and you say, well, here is this cyst enlarging the cord, but is it enlarging the cord? Or is the cord just being adhesed anteriorly, and that's really not causing cord enlargement? And here you can see the same thing. So we have a progressively distorted cord, I prefer to say, with scarring and adhesions as a probable cause of the neurological, worsening neurological picture. And if we do a phase contrast CSF flow with the proper VENC, we can see the flow comes down and it abruptly stops here. So you'll say to yourself, well, so what? So you saw that. But this may give the surgeon reason or clue to go in and take down these adhesions anteriorly. Well, if you had the adhesion posterior, do the same thing posteriorly, because remember, this is a patient who is worsening neurologically. It's probably the only hope the patient has of arresting progressive neurological dysfunction, and we can help by actually demonstrating that there's an abrupt cessation of flow at these various areas. So let me give you an example. Here's a patient pre-untethering, and you can see this large cyst within the cord, and there's nothing much to say about it. Notice the patient has not been adequately decompressed initially. So pre-untethering, the phase contrast shows abrupt halt of the normal pulsations of CSF. Post-untethering, you can see this is the freeze-dried dura, the manufacturing, if you will, of a large subarachnoid space posteriorly. Immediately, the cyst just decompresses. No need for a shunt in there. And now the CSF flow study shows restoration of fluid flow posteriorly. There may be still some minor adhesions anteriorly, but look at the result. So this is an important radiological examination, we feel. So flow reestablished. And another thing that we're all getting used to seeing now, whether it's post-traumatic or idiopathic, is this issue of cord herniation. Now, this patient had an old compression fracture in the upper thoracic area. The cord is deviated here, and then the question always comes up, is the cord pushed anteriorly because there's an arachnoid cyst, subarachnoid cyst posteriorly, or is the cord herniating through a dura? It's an important observation to make, because in this case, you can see the dura here, and the cord is actually herniated through that, and the cord is small, probably because there's been vascular changes within the cord over a period of time, and that's one of the reasons this patient was worsening. So that's the question, and of course the diagnosis is cord herniation. This is one of the sequelae of spinal trauma, so we have to be aware of that. There. So now, the last few minutes here, I want to talk about new avenues of MR research. Now, for those of you who are clinical radiologists, hopefully you find some interest in this, but there's a lot of new things that are going on in MR research in spinal cord injury. We all know that diffusion-weighted imaging has played a very prominent role in brain imaging, not so much in the spinal cord. Many people are working on it. There are a lot of problems with diffusion-weighted imaging in the spinal cord because of motion, because of the small tissue you're dealing with, because of pulsation artifacts. But we're getting close. In animal research and in human investigations, diffusion-weighted imaging is giving us a clue of whether what we see in spinal cord injury is a result of the immediate injury, or could it be a result of secondary vascular disease or infarction in the cord. And we think that this is a component of cord injury which has long been not totally appreciated. We do spectroscopy of the thalamus for central pain receptors, and I'll talk a little bit about dysesthetic pain in patients who have had spinal cord injury, and what we can evaluate in the brain in patients with spinal cord injury. And, of course, determination of CSF flow velocities, which I've already mentioned, and CSF flow imaging. We do have to mention the difference between animals and humans in spinal cord injury. And this is a great barrier to people who are trying to figure out ways of cord regeneration, because after all, you have to start on the animals, and hopefully the animals have a response similar to humans, but it's not the case. The neutrophilic response, the inflammatory response between humans and animals is much greater in animals. That's number one. Number two, demyelinization is more widespread in animals. And of course, you know that if you have a spinal injury and you destroy the myelin, there's breakdown products of myelin, and that myelin inhibits axonal regeneration. So the products of demyelinization or myelin loss is a barrier. The same way the neutrophilic response is a barrier to regeneration, because the neutrophils release proteases, which then secondarily destroy neural tissue. So there's all sorts of strategies going on to figure out how to lower the inflammatory response in spinal cord injury and how to lower the effect of this breakdown products of myelin in spinal cord injury. But you have to do it in animals first, and these are some of the barriers. This is why we haven't seen as much progress as we had hoped in rehabilitating spinal cord injury patients. The astrogliosis, the glial response in humans is modest. It's very significant in animals. So I can say that there's been disappointing results in restoration of significant functional recovery in injured animal laboratory animals, even with different treatment schemes. So this is an important thing. Diffusion-weighted imaging in human spinal cord injury to evaluate associated vascular injury. As I said in Wallerian degeneration, when should we time any kind of intervention? Should we use diffusion-weighted imaging to look at the loss of anisotropy in the white matter tracts within the cord? These are all important questions. Chronic injury. This affect the effectiveness of therapeutic measures. This has been done in some animals using diffusion-weighted imaging after various strategies. Stem cells, neurotropic growth factors have been used. Well, we know that if we do a color tractography in a cord, and here is some work we did on a postmortem. This is a normal cord, and red signifies tracts going up and down cortical spinal tracts perpendicular to the plane of imaging. Below an injury site, notice the loss of anisotropy in the cortical spinal tracts, but continued anisotropy in the ascending spinal cerebellar tract. So this is something that's going to be used in vivo, I believe, fairly shortly, looking at the loss of white matter tracts in the spinal cord. Now, another thing we've done is this issue of neuropathic pain, this dysesthetic pain that does not follow any dermatomal type of distribution, is particularly disabling to patients with spinal cord injury. And no one knows why they develop this type of pain. Well, we looked at and happened to publish in the AJNR a couple years ago our observations in the thalamus in these patients. We all know that the thalamus is a way station for ascending sensory input into the brain. And we divided these patients who had spinal cord injury with no pain and those patients who had dysesthetic pain. And one thing we noticed, and this was a blinded study, people who weren't aware of which patients had dysesthetic pain and which didn't, a definite change in the signal on T1 weighted images in the thalamus in those patients who had dysesthetic pain caused by spinal cord injury. And so we have a whole bunch of hypotheses of what that is, but then we followed this up with MR spectroscopy in the thalamus. We noticed, first of all, the thalamic hypointensity, and then we did MR spectroscopy. And just to bring this down to a very basic level, we noticed there was decreases in NAA in the thalamus in neurotropic pain. patients and not in those who didn't have that time of this aesthetic pain. And the myo-inositol increased. That's a glial response as the pain increased, so there was a definite one-to-one relationship. These, I think, are important observations. Get to explain to us why these patients are suffering so much. And the hypothesis is that there's upregulation of the blood flow to the thalamus. There's increased perfusion, increased blood flow, and that causes the hypothalamic hypointensity. And there's changes in the metabolites in the thalamus also. These are findings similar to animals. So what are the future possibilities in spinal cord research? Are we going to be able to take these axons and put them back together again? Are the basic researchers going to be able to ever use stem cells? There are future possibilities, and what are these future possibilities? Neuroprotection. What do we mean by neuroprotection? There has to be a way to improve the survivability of the neurons that are there. And as I mentioned, the inflammatory response is significant. And even the blood that gets in there, the iron in there speeds up lipid peroxidation. So we have to figure out a way to protect the survivability of neurons and to decrease the amount of apoptosis, that is cell death. The growth factors that are used in transplantation we have to use to wake up hibernating neurons. There's a theory out there that there are a lot of neurons that are viable in the injured spine, but they're asleep. And neurogrowth factors have to be used to re-energize them, to make them wake up, so to speak. And there are these brain-derived neural growth factors, glial-derived neural growth factors that are being presently used. Stem cells change the environment of the injury. Whether they'll ever be successful, however, in actually causing connections is another issue. There are a lot of problems. If you start reestablishing circuits within the spinal cord, you don't know what you're reconnecting. And that's one of the big problems that people are worried about, is you start making aberrant circuits and you could lead to very disruptive symptoms, maybe worse than the patient already has. So this is why some of this animal research. And of course we know that the spinal cord has tremendous plasticity. In younger patients, more plasticity than in older patients, the same as in the brain. So combination therapies will be the mode of the future. So myelin debris, inflammatory changes, all cause a block of neural tissue regrowth and are hampering our efforts to cause reestablishment of normal neurons and axons. So I'm just going to end here by mentioning some of the work that's been done. There's been attempts to actually surgically reestablish bridges across injured spinal cord using peripheral nerves, and this work was done and published in Science a number of years ago, where grafts were actually taken from peripheral nerves and attached gray to white matter to gray matter, and made experimental animals perform again. Unfortunately, these results have not been reducible. So this, and you probably remember that this came out in the lay press about 4 years ago, 3 or 4 years ago, was thought to be a tremendous advance in rehabilitating spine-injured patients, and nobody has been able to reproduce these results, or they've been meager reproducibility. So, in summary, what does radiology have to offer in all these investigations? I believe that in the future we'll be able to use diffusion wave imaging and tractography to determine connectivity of future schemes. We'll be able to determine the in vivo extent and presence of even the most minor areas of hemorrhagic injury of the cord, and the inflammatory component of the cord, which is very important. And we're actually starting a study now to look at the inflammatory response within peripheral nerves and central nerves. So this is hopefully the end result of all this work. And again, I want to thank my host for inviting me and giving me the honor to say a few words about Irv Khrushchev, a great friend, and to speak to you all this morning. Thank you.